of all, thanks to chairperson for kind words of introduction. As I decided when I was making the program that I will not be the part of any scientific engagement because of so many other organizational engagement which I was having. And then last moment, one very important person who was supposed to give a talk is not there. So she told me that she can't come because she had gone to Kumbh Mela and where she got engaged in such a way that she could not come back to Ahmedabad. And that's the reason I'm giving a talk. So I'm not changing anything and thanking Sanofi for support to Diabetes India for this Congress and to me for this particular talk. So what I'm going to talk in next 20 minutes, the where we can use the secondary or the second generation, the insulin. But this is very, very interesting data. And I always talk about the landmark is an only first large scale longitudinal and prospective observational. It's a real world data. And this real world data for everyone, we all as a primary care physician, all our industry partner for everyone to see that two-thirds of our diabetic patients are actually not controlled. Out of five, four patients are not controlled. I am actively involved in organization. I am actively involved in CMEs in education program, but we could not change this figure in last 25 years. We all engage ourselves in lot of scientific activities. We try to train ourselves as well as our colleagues, but this is the real scenario with lot of new molecules had come, lot of new data had come, but nothing has been changed. Less than 1 in 4 Indians have established type 2 diabetes patient is taking insulin. So our insulin taker are also low, and this is improving. I know before 20-25 years we were debating the people with that this person should be on insulin, and there was a debate between triple drug and 4 drug and quadruple and 5 drug. Now we improved, but still it is very less, and the average A1C is 9.2, which is something which is I think always I feel shame when I tell that this is the A1C which we have in India. We run more than I think 200 conferences, regional, local, national, so many meetings which we do, and this is the average HbA1c. So the person with diabetes is actually not getting benefit whatever best we have today in our treatment scenario, but still we can't do it. Why it is happening? I think one is that we are not early and aggressive enough. And this is also in situation that first 10 years of a diabetic patient, as he does not have any complaints, he does not develop any complication, he goes to the doctor or he goes to his primary care physician even after 5 year or 10 year, and he feels that nothing is going to happen because he is not having any complaint. And even you tell him that, you need to be very aggressive. Something at this level, we are not doing anything. When they come to us, maybe most of us who are consultant, they come somewhere here when their already average expense is high and they have developed some or other complication in their life, and when they need some aggressive management, but still the previous last 5 or 10 years of your uncontrolled diabetes leads to a lot of complication to them. What's the advantage of this second generation basal insulin over first generation? But I always see the advantage from 1922 or 1921 with commercial available insulin which was available. There is a constant evolution in insulin. And why it was so? Because every time we were finding some difficulties with the existing insulin which was already there. Like in 1923, we were just killing the dogs and getting the insulin. It was very crude. They tried to purify it, but then it was a short-acting insulin. You had to give it 4 times, 5 times, but still there was no basal. Still people were developing a lot of diabetic ketoacidosis. They put zinc in it, they made it NPS, they tried to make it longer acting. Then over a period of time they found that this NPH is working, but actually it is not working 24 hours, so you have to give twice daily. Then they found there is a lot of hypoglycemia because it's having a peak and peakless also. But we done all those things for almost 75 years. I can say from 1921, 22 to almost 1998 when we had first time a glargine insulin came, and before that a Humalog, a Lispro insulin. These were the analog insulin. In between, a lot of things had happened. We moved from animal to human to purified to again with premix insulin, all those things. But that took 75 years. In last 25 years, a lot of things had happened. So the first time when the glargine came, it was a wonderful drug because we moved from NPS to glargine. It's like something which was causing actually hypo and hyper. We all stopped using NPH almost in our clinical practice in last 10 years. When we started talking in 2000, there was debate why you want to use such a costly injection when there is a NPH available. But it had shown the benefit, and in last 10 or 15 years, we moved from NPH to Glargine. But then Glargine was not again the extraordinary insulin. We found that it sometimes not working for 24 hours. We found that actually it is, you have to take it right at the same time. If you give in the morning time, again you have to give the same time. Still it is working is almost only 23 hours. But it really worked very well. And it had become a standard of care. When you talk of basal, now we don't talk about NPH. Basal means it's a Glargine. That's a standard of care. But still we need second generation. And second generation basal insulin, what's the advantage? One biggest advantage is less hypoglycemia. For anything what we are doing in diabetes patients, we want aggressive control, but we don't want hypoglycemia. So when you are giving insulin, you don't want the person to develop hypoglycemia. You should try to titrate in such a way that patient will not develop hypoglycemia. So this is the most important thing. But there are many more advantages with the second generation. It should be safe while during titration and maintenance. Minimal weight gain because insulin increases your weight. Flexible in dosing. What flexibility you want? You don't want that person should take every time at 9 p.m. if you have told that Glargine to be taken at 9 p.m. because it's not possible sometimes. You know, at bedtime if I write, sometimes your bedtime is also different. During in last 3 days, my bedtime is now 12 o'clock, and sometimes it may be 9 o'clock only your bedtime. So you need a flexibility of 3 hours minimum because you want it's after 7 or 8 or 9 o'clock in between before 11 you can take it. It should be stable and prolonged enough. So it should really work for 24 hours. That's very, very important part of it. It should have less glycemic variability. It means once you give it, it should work like a flat. It is effective and it should give you sustained glycemic control. And last, very important, that it should cause less and less nocturnal hypoglycemia. So these are some of the very important points which are there in the second generation basal insulin which we are looking for. These are the strong evidence. So, we all are here scientists, also doctor, clinician, but we want that what the scientific evidence. Are you talking all these things without any evidence? Whatever the point which we are writing, is they have any evidence or not? These are the evidence from pharmacokinetic and pharmacodynamic study. So this has been done in lab. Then there is an addition program of this. Then there is a deliver. Then type 1 diabetes who have high risk of hypoglycemia. The patient experience, that is the real world data. Then PKPDS. Again, it was done against Degludex. So, there was again second generation, a good other insulin, which was also compared. Then patient with high hypoglycemia, this is someone who is at a very brittle sort of diabetes. Then there was a bright study, which is a direct comparison between a Degludec and the Glargine 300. There is a one care data, and then in range, which is time in range, which is a concept of now we are no more talking about the HbA1c. We want to talk about time in range. So these are the so many studies which were is been proved, and they had shown that it has got whatever I had told you, that is a strong evidence for Glargine 300. CKD and elderly patient, and this is a one condition which leads to a lot of hypoglycemia, and we all worried when we use in patient with CKD and the elderly people, we don't want them to have hypoglycemia. The requirement of basal insulin may be also less, and we want them a best basal insulin which should not cause a risk of hypoglycemia. Otherwise also we want a good control also in that population too. And what the evidence which we have now, these are the special population. There's comparable HbA1c reduction. You can see here 18% lower risk of any time confirmed hypoglycemia. Robust HbA1c reduction with 1.76%. Somebody may say that why it is causing more risk of, decreasing A1C in compared to Glargine. Both are same. No, because here you can titrate it better. And because the risk of hypoglycemia is less, so you are going to titrate in better way. So you are going to have less and less hypoglycemia, greater A1C reduction even with compared with Degludec also. That comparable A1C reduction with Glargine 100 with 48% lower event of hypoglycemia. So these are I'm talking from these studies, their final conclusion. In addition, it had shown comparable A1C reduction, deliver again with a 27% lower risk of inpatient. It is in the patient who are admitted. Effective A1C reduces across EGFR and effective HbA1c reduction of 1.84 with 12 months of treatment. Very low risk of hypoglycemia too. The BRIGHT study, which is an HbA1c reduction across EGFR subgroup from baseline to week 24. And these are the different data of Bright study, which is talking of greater A1C reduction with glargine 300 when it was compared with degludec. So that's also one second generation very good insulin, but it is head-to-head trial, had shown 0.7% more HbA1c reduction. Again, I told you, it does not mean it is more effective. It is because you can titrate it in a better way, so you are going to have less and less hypoglycemia, and you can have better control too. The primary endpoint, HbA1c target achievement in people with or without RI, which is renal impairment. In renal impairment group and no renal impairment group, HbA1c target achievement in people is also very, very good. And secondary endpoint, which is in baseline month 6 and month 12, you can see the renal impairment group. These are the patients whose HbA1c started with 9.32. They could achieve here up to 7.47. This is real one European pool data analysis. These are the data from 1712 patients with available estimated EGFR at baseline were pooled from 624-week prospective study. This is the after 24 weeks of glargine 300 therapy, decrease in A1C from baseline. This was proportion of patients who were achieving HbA1c were comparable across the subgroup effectively, and incidence of hypo was less across the subgroups also. The deliver, which was in high risk real world data. So as I talked about the Bright study, which was compared, but this is a real world data which has been published with 2,550 patients. Here you can see with the who are switched from basal insulin to glargine 300 and were propensity score MACE to patient who switched from glargine 100 to glargine 300. People with type 2 diabetes, mild to moderate renal impairment, switching from one another basal insulin to another glargine 300, reduction in similar HbA1c reduction, but significant lower risk of hypoglycemia that was there. Initiation of glargine is very safe and effective in elderly in routine clinical practice. So it's become very easy and very comfortable for the clinician to start with the 10 units, and then you can increase the dose with 1 or 2 units, or you can add with the 0.2 unit straight away with the per kg body weight, what we do normally. Deliver 3 had shown the less hypoglycemia after switching to glargine 300 versus other insulin which was there in glargine 100. So now we had not compared with the NPH. NPH we already forgotten, that's over that study, and now we are not doing NPH had already taken care by the glargine 100 because that had become the standard of care. Now we don't talk of the basal insulin of NPH. We are not talking of that. It is all with the basal insulin, which is the standard of care, is a glargine, and glargine 100 was compared with glargine 300. In deliver 3, results demonstrated that switching glargine 300 in older patients with type 2 diabetes associated with similar glycemic control with significant lower risk of hypoglycemia compared to patients who switched to another basal insulin in real world clinical setting. Potential implication of this real world study are improved glycemic control, lower hypoglycemia risk, could lead to better treatment persistence, improved patient satisfaction, and lower cost. These results were potential significant for basal insulin therapy in older adults with type 2 diabetes, since such patients carry a disproportionate risk of hypoglycemia and its clinical consequence. But everyone will ask that cost of therapy, because that's always a challenge when we come. But one admission in a year because of hypoglycemia, if someone develop, I can tell you whatever cost which you have saved for the patient will be gone there. If goes to any private hospital, because then it's a longer acting insulin. I mean, in glargine also, or in an elderly patient or with a renal failure, it's not like that you can go and come out after taking only 25% dextrose. It will take almost 2 days to get admitted, and patient should remain in the hospital too. So the comparable glycemic control with lower rates of documented symptomatic hypoglycemia in type 2 diabetic patients who are compared, and here you can see the data in subgroup analysis and overall study population too. With type 1 diabetes in a fasting patient, this is the a type 1 diabetes. Whenever we are talking of the insulin and when we want to compare, I think T1D is the right choice because there is no insulin, and there you can see here the data with the patient who are compared with the degludec and glargine. And this is the glargine 300 data, and this is the data with the degludec. And this here you can see again with the degludec, and here you can see with the glargine also. So you can see that there is a 23% lesser glycemic variability, and 22% greater insulin peak was seen in insulin degludec in compared to glargine 300. So these are the two very, very important points, and for this I highlighted these two very important. In a one care, this is a real world evidence. Again, in adult with type 1 diabetes using CGM, and here you can see the adults with type 1 diabetes with first generation, they were switched over between glargine 300 to degludec. These are the number of patients in both the arms. You can see almost similar time in range, time above range, and time below range. What was the difference? Difference was favoring glargine 300 for time in range and time above range. So what it shown that yes, hypoglycemia risk was not there. These were the patient on continuous glucose monitoring. Head-to-head trial between a patient who are put on glargine 100 versus 300 versus insulin degludec, and here you can see that time above range was less in the patients who are put on a glargine 300. More stable glucose profile. Again, comparable in time range, less glycemic variability, reduced nictal hypoglycemia with glargine 300, and this had shown with the results. So glargine 300 improves glycemic variability irrespective of injection timing, and that's very important because as I told you that patient, even you are writing them, you are explaining them for glargine 100, which we are doing since last 20 years, that you take at 9 p.m. But it is not possible sometimes physically. Some elderly patient to whom you had given that the son or daughter is going to give the injection them at the maybe at 9 p.m. But for him it is not possible to come right every day at 9 p.m. to give the mother the injection, and that's flexibility is really something very, very important. And this you can see with the patient to whom you put them on glargine 300. This is a flexibility of almost 3 hours. So you can say that patient, I'm writing you at 9 p.m., but you can take between 7 to 11, like that sort of a flexibility you can ask the patient, and you can take any time of that. There is a subgroup analysis of the Orion study. The primary endpoint, incidence of severe and symptomatic documented hypoglycemia during Ramadan, and this is a very important study which has been done during Ramadan. Ramadan is going to come. I'm sure we all write this time. Before 1 month, we decided that for all people who want to do the Ramadan, we had put a free camp, and just for giving them a pre-Ramadan a medical assessment, whether they are fit for doing this fasting, which is a prolonged fasting, and whether they will able to give the best therapy which we can give them. Before 1 month we started, every day we see 10 patients in Jivraj Mehta and 10 patients in my clinic, which we are doing completely free for all those who are going to have the Ramadan from Juapura, and this every day 10 patients on phone call we are seeing. And in this month we are going to publish this data also, maybe after 3 months, that how they have done better by doing their pre-Ramadan assessment. We had to 2 to 5% of the patient, we have to tell them it's better you don't do it, because some of them are medically unstable, they have already hypoglycemia, some of them have severe cardiac or renal issue. But this is just to tell that to all of you, because a lot of people are going to do Ramadan in your city, in your area. Do this because it's very important, something which we can publish also together, but not from the publishing point of view. It is for the society need. It is the need for them because they are doing regular fasting, and this is something which we can do. But this Orion study also shows us, because there are a lot of other fasting, like in Hindus and Jain, the fasting is completely different. So there also you can assess them and how they should do the fasting, which you can also educate them. We have written a diabetes and Ramadan, and I am part of that study group also, which is international. We publish the data, and now we are doing fasting in across the world, different type of fasting. I'm also that expert group in consensus and writing a paper that different type of fasting, how they should take different type of anti-diabetic medication, and what benefit will be there by putting them on a different newer medications too. The compliance, adherence, satisfaction is definitely better with the patients who are put on a better quality of newer insulin. The last slide which we want to put on these newer insulin with pregnancy, because there is a lot of confusion whether we can give them glargine or not, whether they can be on glargine 300. But there is a glargine which can be put in a hospitalized patient also, those who are in a pregnancy. It is safe. The DCGI in 2018 very clearly written that safety of glargine used during pregnancy was examined during post-marketing pharmacovigilance data, and from the 44 countries now they had said that it's safe and that can be used for that. There is a device which is very, very unique with the glargine 300. With the very less pressure you can use it. Very fantastic device which they have. There is a lot of evidence for glargine 300 study for type 1, type 2 and special population, and it is in the where I would like to put on 300 IU. This is a last slide. You give them for busy and erratic lifestyle. You give those who are at hypoglycemia, give them for risk of glycemic variability in hospital patients, in pregnancy, elderly, CKD, and type 1 diabetes. With this, I thank once again. I want to announce that actually I asked myself that I will not be taking any talk, and me and Amit both decided we will not be doing it, but somehow last moment cancellation of the speakers, I had to give this talk.